Hello, and welcome to this activity, Beyond the Eosinophil, Mastering the Complexities of EoE Diagnosis. I'm Dr. Nirmala Gonsalves from Northwestern University Feinberg School of Medicine, and joining me today is Dr. Margaret Collins from the University of Cincinnati and Cincinnati Children's Hospital.
Thank you, Dr. Gonsalves. I'm happy to be here.
Happy to have you here, Margaret. So, our goals for today are to enhance your ability to identify key diagnostic criteria for EoE, to strengthen your skills in recognizing histologic changes beyond eosinophilic infiltration and the role of histologic scoring systems, and to provide guidance on fostering effective communication between gastroenterologists and pathologists to improve diagnostic accuracy in EoE. So let's get started with the first portion of our program, identifying and diagnosing EoE, recognizing key clinical and histopathologic features. When we're diagnosing EoE, it's important to recognize that signs and symptoms vary among children and adults, and there are differences in symptom presentation. In young infants and children, they present with reflux like symptoms, vomiting and nausea, abdominal pain, food refusal, and failure to thrive. When the kids are a little bit older in adolescence and in adults, dysphagia and food impaction are the most common presenting symptoms. Patients may also have substernal chest pain, reflex like symptoms such as heartburn and regurgitation. One important thing that clinicians should recognize is that adaptive behaviors that patients have developed can mask symptoms. So sometimes it's not enough to just ask about dysphagia, but focus on asking a history based on the impact questions. And what we see here are these specific questions that you can ask your patient. So, I imbibe fluids to facilitate passage of solid food. Many patients will attest to doing that. Do they modify foods, cutting them up into small pieces and pureeing the foods to help with the swallowing? Do they have prolonged meal times? Many of our patients will say they are the last ones to leave the table. Do they avoid harder texture foods such as meats or breads because they are sticky in that esophagus? Do they chew excessively to really help puree those foods, to push it down? And do they turn away pills and tablets? They're doing all of this to prevent that food impaction. Due to some of these adaptive behaviors, diagnostic delay in EoE is common. The time between symptom onset of EoE and diagnosis ranged from 1.2 to 3.5 years in children and 3 to 8 years in adults. Findings from a study of 705 patients with EoE who ranged from 6 months to 65 years showed, interestingly, that this time gap increased as the patient age at diagnosis increased. So, for instance, the median time for symptom onset to diagnosis was 1 year in children under the age of 11, 2 years in patients ages 11 to 17, and 4 years in adults. The presence of food allergy and atopic dermatitis was associated with a more prompt diagnosis and was also more common in younger population. Early diagnosis is important for many reasons. Uncontrolled EoE can lead to esophageal stricture. Of patients with severe diagnostic delay, 57% had food impactions and 52% had a stricture. Feeding dysfunction is especially relevant for children. 14 to 60% of patients with EoE have feeding dysfunction, and 21% of children with EoE and feeding disorders also have failure to thrive. And as you can imagine, all of this has a negative impact on quality of life. Here we see our updated EoE diagnostic algorithm from the recent ACG guidelines. And I'll just walk you through this algorithm. So initially, you're going to look for that clinical presentation suggestive of EoE. Do patients have symptoms of esophageal dysfunction, any modification and avoidance behaviors based on that impact score? Could they have feeding dysfunction, concomitant atopic conditions, or a family history of EoE or EGIT? All those should raise our suspicion of EoE. If you have that suspicion, that patient is going to have an endoscopy with biopsy. At the time of endoscopy, we're going to assess for endoscopic features of EoE using the endoscopic reference score, or EREF, We'll assess for fibrostenosis and strict shrink. And most importantly, we'll obtain at least 6 or more biopsies from different levels of the esophagus and targeting findings of EoE in that esophagus. Once we do that and we have esophageal eosinophilia over 15 eosinophils per high power field, and we have evaluated the differential diagnosis of EoE and ruled out these other conditions on the right side of this slide, we have essentially made the diagnosis of EoE. Some important things to consider when you're ruling out these other causes of eosinophilia are reflux, esophagitis, drug hypersensitivity, non EoE agents, hypereosinophilic syndrome, Crohn's disease, achalasia, infections, and connective tissue or autoimmune diseases. These are very common endoscopic findings that should clue us into that diagnosis of EoE and lead us to taking those biopsies. These are these concentric mucosal rings here in this upper left panel where that esophagus can look like a trachea. These longitudinal or linear furrowing or creases in the esophagus on panel B. White plaques or exudates, these white speckles in the esophagus in panel C, and they correspond to eosinophilic microabscesses. And of course, in panel D, the dreaded complication of a food impaction, a food bolus. And here we see a piece of chicken in a patient's esophagus due to stricturing. I mentioned that endoscopic reference score. When you are doing endoscopy, it's very important to recognize these endoscopic features and record them in the EoE endoscopic reference score or EREFS. Now, these common findings are listed here in the score: E for edema, R for rings, E for exudates, F for furrows, and S for stricture. Here we see a nice atlas of these different findings. Grade 0 on this left panel is just a normal esophagus. For edema, they can be grade 1 or decreased, grade 2 or absent vascularity entirely. Rings can be very mild or subtle in grade 1, more prominent and moderate in grade 2, and grade 3 essentially means a regular adult endoscope cannot pass through those rings. Exudates are mild or less than 10% of the surface area, or severe, more than 10% of the surface area. Furrows can be very mild or very deep in depth, and strictures are graded as either present or absent. What further increases that diagnostic yield, we know that EoE is a patchy disease, and we need at least 3 biopsies from the distal and 3 biopsies from the proximal esophagus that should be taken to help increase that sensitivity and specificity. Furthermore, in addition to taking at least 6 or more, you really want to target those endoscopic lesions to increase that diagnostic yield. So if you see those exudates, you see those furrows, that's what you want to target to help get that diagnosis. So let's move on now to a clinical case. This is John, a 28-year-old man. He reports increased difficulty swallowing meat and bread for the past 6 months. He often needs to drink water to help food go down and has had 2 recent episodes of food impaction requiring self induced regurgitation. He has seasonal allergic rhinitis and mild intermittent asthma. He takes occasional loratadine, and he has a father with atopic dermatitis and a younger sister with celiac disease. His physical exam is unremarkable, and his upper endoscopy shows longitudinal furrows and concentric rings in the esophagus. He has mild narrowing or structuring noted in the mid esophagus. 3 biopsies were obtained from both the proximal and distal esophagus, so 6 in total. And his pathology finding shows 25 eosinophils per high power field in both the proximal and distal esophageal samples. So, does this suggest EoE? Well, there are certain clues about that intermittent dysphagia, the self limited food impactions in a patient who's atopic and has all these endoscopic findings. So, certainly, this is very classic for a diagnosis of EoE. One thing that you can use when you're diagnosing a patient with EoE is a tool called the IC index, which can assess disease severity. This measures symptom features and complications along with inflammatory and fibrostenotic features on both endoscopic and histologic examination that can be completed at routine visits to assess EoE severity using a point scale. And this has been made into an easy to use app through the AGA. The point scale is 0 to 6 is mild, 7 to 14 is moderate, and over 15 is considered severe. And this is what it looks like. And there will be additional tools for you to look at, but just in a broad sense here, there are different points ranging from 1 to 15, and we grade symptoms and complications, such as how often dysphagia occurs, complications such as food impaction and need for hospitalization, inflammatory features, whether the inflammation is localized or diffuse, the level of eosinophils, and even that fibrostenotic change if that scope cannot pass through. These are all given points, and those points can help you identify patients' severity of disease. So, with that, I would like to turn the next portion of the program over to Dr. Collins.
Thank you, Dr. Gonsalves. So, eosinophils are not the whole story when it comes to eosinophilic esophagitis. Histopathology scoring systems are useful because they facilitate a comprehensive and a consistent biopsy evaluation that will track changes over time, such as the impact of therapeutic agents on the esophageal tissue, and they may reveal aspects of the disease under study. So, for eosinophilic esophagitis, the histology scoring system, or EoE HSS, was developed and it quantifies or semi quantitatively analyzes 8 abnormalities in esophageal biopsies that are obtained for EoE, only one of which is related to the peak eosinophil count. And that one is known as eosinophil inflammation. In addition to that, we see the other 7 abnormalities, and we'll see them illustrated on the following slides. We know now that the EoE HSS that grades the abnormalities as severe using a grade score and also analyzes the extent of the tissue that is affected by the abnormality as a stage score on a scale of 0 to 3, that this is a responsive scoring system, meaning that it changes in the way that you think it might given the clinical situation. So, someone who has not ever been treated for EoE, we establish the diagnosis. They're given a therapeutic intervention. When they return, they say they're feeling much, much better. Their symptoms are much reduced. The EoE HSS score is less, so it's responsive. You can count on it to aid with the evaluation of the clinical setting. It's also reliable or reproducible. It can be used by any pathologist. And here it is, and here are the abnormalities. In the lower left panel, there's a high power view of eosinophils. They're not difficult to recognize in biopsies and tissue sections. They have a very distinct appearance. They're super red granules in their cytoplasm, which you can see in the photograph there. So in the upper left, the bar is demarcating basal zone hyperplasia. That means a thickening of the epithelium in the esophageal inner lining. It's supposed to be 2 or 3 cell layers thick, and this is that bar is demarcating almost the entire depth of the epithelium is occupied by that basal zone. It's very abnormal. Arrows are pointing to eosinophils, which we just saw a high power view of. Arrowheads are pointing to dilated intercellular spaces. So there shouldn't be any spaces, any white areas around any of the epithelial cells that are lining the esophagus, and there are a lot in that photograph. The asterisks are demarcating lamina propria fibrosis. The one on the left is showing a thick fiber. That's not what normal lamina propria looks like. further down in that photograph, the normal appearance of a lamina propria is present, very thin, delicate fibrils, not a really thick fiber. In the lower left, where the white asterisk is, that's a very substantial eosinophil abscess. Arrowheads are pointing to eosinophil surface layering, where the eosinophils line up along the surface of the epithelium just under the lumen of the esophagus. In the upper right, the arrowheads are pointing to eosinophils that are admixed with surface epithelial cells. There's an arrowhead pointing to them that are more pink than they should be. They have more keratin in them than they should be. That is a response to irritation, likely, and that's known as surface epithelial alteration. And then in the lower right, there are cells that are very pink in color that are um, dyskeratotic epithelial cells. They are different from eosinophils. They don't have those really red granules in cytoplasm. They're very pink cytoplasm, but they don't have the granules that are characteristic of eosinophils. And so we divide the scores into subscores sometimes. And the inflammatory subscores are abscesses, eosinophil abscesses, surface layering, eosinophil surface layering, surface epithelial alteration, and eosinophil inflammation, score that's based on the peak eosinophil count. The architectural or the structural changes are comprised of basal zone hyperplasia, dilated intercellular spaces, and dyskeratotic epithelial cells, along with lamina propria fibrosis. So, why do this? Well, this will track changes over time. And sometimes these scores reveal things about the disease that wouldn't necessarily be discovered without attention to them. So, for example, basal zone hyperplasia. You know it's not supposed to be there. We now know that the epithelium in eosinophilic esophagitis is a master regulator the chemokines, the cytokines, the other substances that are involved in the genesis of eosinophilic esophagitis. And in addition to that, in patients who have been treated, whose biopsies show either fewer than 15 eosinophils in a high power field or no eosinophils, but who have ongoing symptoms, they sometimes have persistent basal zone hyperplasia, which raises the question, is that hyperplasia causing those symptoms and providing another target for therapy? Same with dilated intercellular spaces. They are associated with reduced impedance. In other words, they allow molecules that normally don't pass over the esophageal epithelium to get into it, as discovered in this study in which gliadin, a component of gluten, was found in the epithelium of esophageal biopsies that have dilated intracellular spaces compared to those that do not. This suggests that these spaces, which persist frequently, are responsible for a trafficking that is abnormal and potentially contributes to ongoing disease. Surface epithelial alteration and dyskeratotic epithelial cells, when they're both present in a biopsy, predict the presence of lamina propria fibrosis. This is important because many times lamina propria is not present in the biopsies that we evaluate. And when it is, sometimes it is crushed because of the pinching motion that's used to obtain the biopsy and cannot be evaluated. So having these two as markers of lamina propria fibrosis is potentially very helpful. And here is an algorithm that's available online that uses patient age as well as the scores, the grade and the stage scores for these two abnormalities to predict whether a patient has lamina propria fibrosis or not. And finally, one of the EREFs abnormalities that Dr. Gonzalez just illustrated, along with several of the EoE-HSS abnormalities, have a very high specificity and sensitivity for predicting active eosinophilic esophagitis. And just before we leave this tour of uh, pathology in the esophagus, basal zone hyperplasia may be responsible for ongoing symptoms in patients who don't have eosinophil inflammation, but sometimes it's not hyperplastic in patients who have ongoing symptoms and their EOs are gone. There's the whole rest of the wall that we're not seeing in biopsies. What we see, the endoscopic biopsies is about this, a little bit of this and the epithelium. There's the muscularis mucosa, the submucosa, most of all the muscularis propria, where there may be inflammatory changes that we're not aware of that could be contributing to symptoms. We need to keep that in mind always.
We'll now move on to the next segment, which is very important, highlighting improving multidisciplinary collaboration between gastroenterologists and pathologists. So, why is collaboration here important? EOE is a clinical pathologic diagnosis. Accurate diagnosis requires both symptom assessment and histologic confirmation. Like mentioned, at least 15 or higher eosinophils per high powered field. Clinical pathologic mismatch can be common. Patients may present with typical EoE symptoms, but have borderline or patchy eosinophilia or vice versa. So, close communication improves accuracy. Pathologists need clinical context, such as age, symptoms, and location of biopsies, and gastroenterologists need detailed histologic feedback beyond just the eosinophil count. So, the takeaway and the important message is that when clinicians and pathologists engage in this bidirectional dialogue, they can avoid under or over diagnosis of EoE and guide appropriate treatment decisions.
So, optimizing biopsy protocols and histopathologic review is obviously important. Standardized biopsy collection optimizes the possibility, the probability of making the right diagnosis for a patient undergoing endoscopy, either at baseline or following a therapeutic intervention or following onset of new symptoms or for monitoring. So, obtaining at least 6 biopsies, as Dr. Gonzalez has already said, from both proximal and distal esophagus is essential. Labeling those samples as to where they came from is also very important. We cannot look at biopsies from the esophagus and know for sure which came from the distal and which came from the proximal. Allowing us to know where they came from by putting them in separate jars that are uh, accurately labeled permits us to, for example, make correlations with the endoscopic findings and perhaps with the location of symptoms that patients are complaining about. So, including clinical indications is also important. Rule out EoE is fine. It is helpful. It's better than nothing. But having more details like solid food dysphagia for 6 months and especially history of ATP really strengthens the ultimately the pathology report because the pathologist is more likely to be more assertive about the possibility that this patient does not yet have a diagnosis of eosinophilic esophagitis, but that must be strongly considered in the differential diagnosis for this patient. So, detailed pathology reporting. I've just gone through the EoE HSS. It's a good thing for gastroenterologists to ask for those abnormalities to be evaluated, especially basal zone hyperplasia, dilated intercellular spaces, and lamina propria fibrosis. The whole formal scoring doesn't have to be done clinically. The scoring can be done dichotomously, present or absent, but it really is a good idea to look for all 8 abnormalities. Most of the time, as I said before, lemon appropriate isn't there or else can't be evaluated, so then it's down to 7. And the eosinophil inflammation is based on the peak eosinophil count, which is being obtained, should be obtained already. So now we're down to 6. And with a little bit of experience, it becomes second nature to say yes or no as to whether those abnormalities are present. And so using a structured template where just a list of the 8 of them and column that's yes, column that's no, so pathologists can check yes or no whether they're there or not, will be helpful both for diagnosis and to track changes over time, to track changes that are associated with a particular therapy. And so if the symptoms associated with that come back, it's known what therapy will be helpful to use in a particular scenario. And of course, synoptic reports, whenever possible, to standardize terminology across cases.
So let's move on. Thank you for that review. Let's move on to a clinical case. This is Matt, a 7-year-old boy. He has chronic abdominal pain, poor appetite, and episodes of gagging while eating. He's had these symptoms for 9 months. His meals take an unusually long time. He prefers soft or pureed foods, and he complains of food getting stuck. He has mild atopic dermatitis and allergic rhinitis, and his growth chart shows that he's below the 10th percentile for weight. His allergy testing is positive for dust mites and tree pollen. His lab work does not show any evidence of anemia and a normal eosinophil count in the blood. He is referred to the pediatric GI with a referral of a clinical suspicion for EoE. Endoscopic findings show mild rings in the mid-esophagus, no exudate. Biopsies are taken from the proximal, mid, and distal esophagus. And the eosinophil count here is stated to be ranges from 10 to 14 eosinophils per high powered field with a comment mild increase in eosinophils. Findings are not definitive for EoE. So, how should the gastroenterologist respond to the pathologist's report when we are really suspecting EoE in this clinical scenario? So, one way the gastroenterologist should share a detailed symptom history. And like Dr. Collins mentioned, this patient has dysphagia. I'm concerned about EoE. Confirm the biopsy sites where the biopsies were taken, that it was proximal, mid, or distal, or just proximal and distal, and request review for additional histologic features. If those eosinophils aren't there, ask about the other features that Dr. Collins mentioned in her lecture, basal zone hyperplasia and dilated intercellular spaces.
And the pathologist should re-review uh, the, the slides at the gastroenterologist's suggestion, and chances are they'll find areas where there are more than 15 or more eosinophils in a high-powered field with an initial count of 10 to 14 in a high-powered field. Likely they will find what it is that we're looking for the part of the diagnosis, the pathologic part of the diagnosis of EoE. Basal zone hyperplasia that's affecting more than half of the epithelium in the biopsy, that's very significant. That suggests that it might have been ongoing for some time. It's potentially a sign of chronicity in the tissue. Dilated intercellular spaces, they can be problematic, and the microabscess is none of these are pathognomonic for eosinophilic esophagitis, but a microabscess with not so many eosinophils in the esophagus is that certainly makes one think again of eosinophilic esophagitis. Diagnosis, of course, requires that the pathology and the clinical setting be merged together. But that should make one begin to suspect strongly eosinophilic esophagitis.
Exactly. So, all of these things really highlight the importance of discussion and collaboration between the gastroenterologist and the pathologist, particularly in these areas where the diagnosis may be a little bit muddy. But after that discussion in this clinical scenario, the diagnosis was made of EoE. So we'll move on now to our last segment, which is targeted agents and the future of EoE management. So here we see the EoE suggested approach to management, the updated guidelines from the ACG. And this seems like a very busy slide, but I'll just walk you through the key points. So once you have EoE diagnosis established, you're going to treat inflammation and assess for fibrostenosis in all patients. You want to assess inflammation, treat inflammation, and assess those areas of narrowing. You're going to start patients on anti inflammatory treatment, either pharmacologic treatment or diet elimination treatment. And here is where shared decision making is really important. Having that discussion with the patient about their goals of care and helping to guide them through one of these two routes. If they choose pharmacologic treatment, options could be a PPI or swallow topical corticosteroids. And after that, you want to assess response. It's very important to have an endoscopy after treatment to assess response. If you have response, you're going to go into maintenance therapy and long term monitoring. If you have a non response here, you can change or modify your prior treatments. You can move on to biologic therapy, such as dupilumab. And after you change these treatments, you're going to again assess response to make sure that you have adequate suppression of inflammation. If you have response, you're going to go through maintenance therapy and long term monitoring. Again, if there's no response, you're going to go back up here to this top bubble and change and modify prior treatments. If you choose diet elimination treatment, the recommended approach is empiric elimination. So, taking out the common food antigens that are triggering EoE, whether it's one food, two food, four foods, or six food. Again, that's shared decision making with your patients. After that, you're going to assess response. If you have a response, you're going to go on into that maintenance therapy, long term monitoring. And if you do diet elimination, you're going to reintroduce those foods to find food triggers. Along this treatment pathway, it's very important to assess for fibrostenosis. And if stricturing or narrowing is present, to perform that esophageal dilation. The goal diameter of that esophagus after we're done with treatment and dilation is 16 to 18 millimeters to help prevent those food impactions. It's important to recognize the concept of treat to target in EoE. What are the appropriate endpoints in EoE? Well, it's multifactorial. One, we want improvement in symptom activity. We want improvement in that dysphagia. We don't want our patients to have to be dealing with those impact symptoms and modifications. So we want improvement in symptoms. We certainly want improvement in histopathologic activity, improvement in that esophageal eosinophilic inflammation, driving those eosinophils down to under 15. And we want improvement in endoscopic activity, the inflammatory features seen on EREFs, and the fibrotic features, improving those strictures to at least 16 to 18 millimeters. Now, this slide highlights that we really want a complete response. We want to hit all three of these targets, hit that bullseye, so to speak. So, for instance, if we improve histology, but we still have a patient with symptoms and endoscopic inflammation, we haven't met that target. So, we really want to focus on all three of these. Let's dive a little bit deeper into the histopathologic insights and the treatment.
Histopathologic insights and treatment are obviously very important. The insights in EoE are increasingly important, not just for diagnosis, but they may also be helpful in guiding treatment decisions. They may help differentiate eosinophilic inflammation from chronic remodeling. So, the eosinophil subscore may tell one story about how a treatment is proceeding, and the architectural or the structural subscore may tell another story. The inflammation may be getting better with the treatment, but the structural and architectural uh, abnormalities, such as basal zone hyperplasia and dilated intercellular spaces, may not be improving. And that may require attention. Marked basal zone hyperplasia, dilated intercellular spaces, subepithelial fibrosis or appropriate fibrosis may suggest a more refractory phenotype, especially if they are persistent, and that's where a scoring system helps. You can look back and see how long those abnormalities have been there. These patients may benefit from targeted therapy earlier in the treatment algorithm, and histopathologic evidence of persistent disease may help support clinical justification for insurance coverage. And these insights may enhance shared decision making with patients. For example, explain the rationale for targeted treatment, reinforce the need for long term treatment adherence, etc.
So, in summary, eosinophil count alone may not reflect disease activity or burden. Other histologic changes contribute to symptoms and chronicity. Scoring systems such as the EoE HSS enable structured assessment of multiple histologic domains, and that includes basal zone hyperplasia, dilated intercellular spaces, lamina propria fibrosis, and more. Basal zone hyperplasia and dilated intercellular spaces are markers of epithelial injury and barrier dysfunction, and this may persist even when eosinophil counts improve. Fibrotic changes, such as lamina propria fibrosis, suggest chronic disease and may predict stricture formation. Importantly, effective collaboration between gastroenterologists and pathologists can facilitate accurate diagnosis of EoE and guide appropriate treatment decision. Beyond diagnosis, histopathologic findings may help inform therapeutic strategies. So, thank you so much for joining us today. And thank you to Dr. Collins for providing her insights to this discussion. We hope you found this activity to be useful to your point.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partners, Rodger C. Haggitt Gastrointestinal Pathology Society and United States and Canadian Academy of Pathology. This program is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi.